Now we move to the second session, which is on rectal cancer. And our chairperson is Major General Dharmesh Soneji. May I invite you to give the initial comments, please.
Good afternoon, everybody. My sincere thanks to the organizers for calling me here for this. The session on rectal cancer, and ever since the talk would be mostly on, or it will be focused on the locally advanced, that's T2, CT3, and N0, N1 rectal cancers, and ever since the chemoradiotherapy and adjuvant chemotherapy got incorporated since the early 90s in the treatment of rectal cancers, the treatment paradigm has shifted quite a bit in the next 2 or 3 decades. Initially, it was CCRT, then it was short course versus long course radiotherapy. And then, of course, in the last few years, we have got a total neoadjuvant therapy. The Rapido trial and then the Prodigy 23 trial, in which they intensified the chemotherapy with FOLFIRINOX followed by a conventional radiotherapy. Again, the debate and the trials have been between a short course and a long course, the intensity of chemotherapy, and then the sequencing as an APO AIO 12 trial, in which what is the sequence which is better, usually to a CCRT followed by radiotherapy, followed by chemo, and then the of course surgery. Now, in these 2 trials which we are going to discuss today, as we are trying to fine-tune the treatment for rectal cancers, can we do away with one of the modality of therapy in the treatment of rectal cancer? The first one discussion is the prospect, in which they have used FOLFOX upfront and not instead of CCRT, and try to find out a disease-free survival. It's a non-inferiority trial, and the results have been quite encouraging, in which if we can look at if we can do away with radiation in rectal cancer. The second is the other end of the spectrum, in which they have used intensified radiation, the OPERA, which is going to be discussed here, and in which they have tried to intensify the chemotherapy. The 2 arms, one which has got giving the boost to this external beam RT, a second was with the brachytherapy, and brachytherapy obviously scored over it. So without much ado, I call upon the panel discussion, and the person who would be coming and discussing the panel, the moderator. May I call upon Dr. Ankur for moderating the session? Sir, can I call the panelists also? I would ease your job, and the panelists for this are Dr. Kanika Sharma, Dr. Harit Chaturvedi, Dr. Viraj Lavingya, Dr. Ritesh Sharma, Dr. Nikhil Agarwal, and Dr. Nilesh Lokeshwar. Thank you, panelists, and over to Dr. Brother.
So thank you so much, Dr. Amish, for giving this opportunity, and the disclaimer which Dr. Parikh put on the WhatsApp group, that be prepared, do not come like this, and all the panelists has to be thorough with the paper. And this is oncology beyond the obvious, but if we look at the picture of this iceberg, obvious oncology is still the gold standard, and how much we can move beyond, and how much because these next 2 papers can be controversial. One paper is saying that surgery is not required, and the other paper is saying radiotherapy is not required. What we are preaching in last 2 decades is that the tri-modality gives the DFS and the OS advantage. The Germans in 2004 clearly said that concurrent chemoradiation, and again in 2004 adjuvant chemotherapy gives survival. So this discussion in next 25 minutes or 25 minutes each paper can become a bit controversial, but we'll stick to the science. So this is the first paper, which is OPERA trial, which says neoadjuvant CTRT with radiation dose escalation with a technique called as CXB, which is contact X-ray brachytherapy, or a EBRT of 9 gray extra can preserve the organ in phase 3 randomized trial. Dr. Kanika, you have to balance out 2 radiation oncologists, 2 surgical oncologists, and 2 medical oncologists. So neoadjuvant chemotherapy with a boost by EBRT or with brachy can omit surgery and can preserve organ in rectum and without stoma, without have any disadvantage with survival. And the other paper is that preoperative treatment with only chemotherapy, omitting radiotherapy and then going for surgery is a non-inferior trial. So it's my disclosure that I'll be an oncologist here. We have 3 specialty here, and the chairperson and the expert will also remain oncologist. Wherever I deviate or we deviate, please bring me back. So what's obvious? Let's discuss first this, and then we will do what is beyond obvious. So Dr. Harith and Dr. Nikhil, can we omit surgery in early rectal cancer? Answer we need is yes or no. This will be my last slide as well, where you have to give comments. Right now, yes or no. Dr. Nikhil, can we omit surgery in early rectal cancer? And early is not T1, it is T2, T3, and in T3, T3A, T3B. So T2 and T3AB, can we omit surgery? Yes or no?
Not binary. I can't.
Yes or no? Look, I'm a moderator. I'm said, now I have to moderate this 50 minutes.
It can be yes or
We
no. It can be
can omit surgery. Dr. Harith?
So I would not omit surgery.
You will not omit, so you, yes, so that's what I want. so Dr. Kanika and Dr. Ritesh, can we omit radiation in locally advanced rectal cancer? Can you?
So you've changed the term. Now it's not early, it's locally
No,
advanced.
no, yes, the question is
So
straight.
for
Locally advanced, locally we'll discuss staging, because Viraj is one of the first author of that Indian consensus rectal guideline, which have clearly told us what to do in Indian setting. So this is a trial setting which was done in UK, Canada, and Switzerland, and some European country, and what we are practicing is institutional based Monday morning practice. So radiation can be omitted in locally advanced rectal cancer?
Not in all. Risk
Not in all.
adapted.
Can in some?
In some, maybe.
Okay. In some. So you've read the paper well. So rectal cancer staging workup. So we follow, so this is 2017, this is the last AGCC staging of rectal cancer, TNM staging T. Can we omit, Dr. Nilesh, can we omit chemotherapy in either? So in both the papers we are common, I mean you are common, I am the...
So as per the opera, concurrent was given, but only 6 patients.
Can you omit? Concurrent means some chemotherapy.
Yes, you can in some patients.
Okay.
Yes, you can.
So we can go with only RT and surgery in rectal cancer and get the best, then the same survival?
Or only IO.
I am talking about MSS.
Oh, not today.
Not today. So Dr. Nilesh feels that he can omit chemotherapy in rectal cancer, whether it is early or locally advanced.
No, in early only.
Without radiation, you want to give only radiation?
Yeah.
see,
So
we
the
can-
last point is you can omit chemotherapy.
We can.
If T2 lesion goes to surgeon and a proper surgery is done and N0 is negative, you don't need chemotherapy.
Yes.
So you can. Answer is that.
Okay.
And also rectum, you have to always think of upper, middle, and lower. Yes.
So Dr. Viraj, so you had, you messaged me this paper in the morning. And so this question comes to you. So localized rectal cancers, and you with Dr. Bhavna and Shefali and Mukta and Aparna Parikh. So what was in your mind in writing this consensus? What stage we get in our Indian population, and whether this stage is similar to these opera and preoperative Folfox only?
Yeah, so we see younger population, more locally advanced. Very few patients we see where we can fit in prospect or opera, what we are going to discuss today. In fact, we have more of Prodige and more of Rapido and younger population. So yeah, so that was the main thing about risk stratifying patients for our subjects.
So, Dr. Nikhil, let's start the panel discussion. We have 38 minutes, and Dr. Atul sir, I will break these two papers, and you have to give expert comment for one paper and then expert comment for second paper, so that we don't mix this. Dr. Nikhil, a rectal cancer patient comes to you, and how will you stage it in your practice?
So distant metastatic workup, local workup, and apart from that routine investigations and CEA. So the most important after metastatic workup is MRI. So that is the workhorse of my decision making. If metastasis is ruled out, MRI is something which I would rely upon very much, and digital rectal examination.
So digital rectal examination, a colonoscopy, and a MRI of an abdomen pelvis, or MRI of only pelvis?
So we can go two ways about it. Either we can do a MRI pelvis with a CT or a PET CT to scan the upper abdomen chest, or we can do a PET CT as well, or I can do a MRI whole abdomen and a CT chest. So it depends on what investigation patient comes to me with, and then I decide my next plan.
So when we talk about a luminal malignancy, whether it is esophageal, gastric, or rectum, so we always have in our mind EUS. So Dr. Harith, EUS as you use in esophagus is same EUS which you use in rectum?
Even in esophagus, we don't use EUS as a important modality for treatment decisions, because once you have got an MRI and a PET and a CT or a PET as the patient carries as Nikhil, right, then we take a call. That is enough. We don't use EUS for that evaluation.
Dr. Viraj?
So unless patient has T1 disease where they want to do TAMIS, that is the only place EUS is required.
So what advantage, Dr. Nikhil, MRI gives you over conventional CT, MRI of the pelvis? What do you want to see in MRI pelvis which helps in the accurate staging, whether it is T2, T3A, T3C, or N0 or N1?
Yeah, so T stage, N stage, whether the CRM is threatened or not, distance from the anal verge, involvement of anal sphincters, distinction between upper, mid and lower rectal cancer, all of these things are made on MRI.
So, and while taking a decision for surgery, what are the most important factors? The T factor is more important, or a nodal factor is more important, Dr.
So
Harith?
the most important thing is CRM.
Dr. Harith?
T and N both. T and N both will be important, but CRM, as you rightly said, is the most important thing.
And
if the node is very
justification to
suspicious,
node will be like post-op, when we have a post-op histopathology.
no,
So how
but
are
on
you differentiating?
MR, it is very suspicious, or significantly, it is more than 6 millimeters, or it is about a centimeter. In that case, the suspicion goes
And
up.
the number of perirectal lymph nodes and the ileal group of lymph nodes, whether you are able to differentiate that this is an N1, this is an N2, or this is a...
Yeah, we can make it out.
Okay.
Nikhil?
Yeah, so basically when we are looking at MRI...
Nikhil spends a lot of time on these MRs, so that is why I said he will give
So when we are looking at this MR, more than T and N staging, what I'm looking at, which protocol I'm going to put the patient in. And there, the most important thing is your CRM. So if CRM is threatened, I go Broadage and Rapido way. If CRM is not threatened, so then we can take either of these trials.
I take it. The CRM is threatened. What stage it makes it?
So the moment the CRM is threatened, it's T3 CRM. It's called TCRM, T3 CRM.
So in TNM staging, it is T2, T3, T3A, T3C.
So when we are talking about a preoperative MRI is clinical staging, and there we don't use the terms which you showed. It's a MR staging on which we base our decisions. So when we talk about MR staging,
so just probably for the most of the people, TNM stage as of now, T3, A, B, C, D probably doesn't consider that way for decision problem. In practice, we do consider, but when we stage TNM probably based on MRI, because probably still it's not one of the standard staging system. That's what I wanted to
So
know.
why I want to emphasize, because both the papers are revolving around T2 and T3. And the next paper is revolving around except T4 and except T1, except more than 4 lymph nodes. So whatever we're discussing is on the staging. That's what I'm saying.
They have used the MR staging.
They have used the MR staging, and that was a pitfall also of this paper, that the MR TORG grading or the scale was not uniform. So my question is, if CRM is threatened, it will be a locally advanced rectal cancer.
In fact, so Ankur probably, if I am not wrong, prospect the NEJM paper, they had taken probably 3 millimeter and beyond they excluded.
Yes.
So 3 millimeter, if you take as per the staging, still it is considered T3B.
Yes.
Am I correct?
So 5 millimeter invasion. 5
Yeah,
millimeter
up to 5
invasion
millimeter
yes.
is B. So 3
So what T1 like T3 A B C in MR is from the rectal wall. And when they say threatened CRM, it's the from MRF, from CRM. So they have used a 3 millimeter margin from MRF. So we cannot put it into any standard staging criteria. So they have kind of devised a new criteria there.
So and the only important thing is, in these cases, you have to discuss the MR in detail. Only then the call can be taken appropriately.
So this is the latest version of NCCN 2024, which has given us 3 options in MSS satellite stable: T3, NEN, T1, T2, N1, N2, T4, NEN. Either we start with long course CTRT, then give 12 to 16 weeks of FOLFIRINOX or FOLFOX based therapy, then restage and then go for surgery. Or we consider chemotherapy upfront, then give long course RT or a rapido, and then restage and then go for surgery. There is one thing more which has come up is that start with FOLFOX, consider pincher sparing surgery, restage with sigmoidoscopy and MRI at week 14, again confirm it at week 24. If the tumor is regressing more than 20%, do surgery. Not regressing, consider RT. So RT is going out in this last one. So this is just a snapshot of NCCN, and I'm not discussing this. Let's go to the paper. Dr. Harit, over last 30 years, how does rectal cancer has changed? What were you doing 30 years before and what are you doing right now?
30 years back, whatever we could remove, we used to remove it, actually.
Yes,
This is
there's
actually
the Dutch.
what we did. And yeah, and when TME came into vogue, we were all very excited that probably we have conquered this, and that plane was very exciting for the surgeons, because if I just look 10 years before this came, we were all doing APRs and all this for even for lesions up to 5 centimeters and above. The standard thing was get the whole thing out, but this changed the practice, and then we started with.
So Opera, which is the first paper which we are going to start now. So what in 2005-06, the radiation oncologist came in, Dr. Kanika, that we have to give pre-op CTRT and then you operate. He was saying we used to operate whatever it comes, then you interrupted in between and said we will give neoadjuvant chemotherapy RT, and then you do surgery for a better CR, for a good pelvic local recurrence, and the DFS benefit of adjuvant chemotherapy may not be an OS benefit, but now you are again going to be out. So how does it feel like?
So we're not going out. So really don't feel bothered, because it is a select subgroup. Yes. It is such a select subgroup, and when we talk of these trials and you see the settings, see so much of discrepancy we are seeing in MRI here. So with no standardization in our disease staging and no standardization in response evaluation, we cannot venture into such things which are still as an option. They're not standards. So unless they become standard, we're still there, and we're still there to be. You can see the papillon. So if you see that the X-ray therapy, 80 years back it was there. We used to just read it and use it in our exams, and now it's back. So things come back in a different fashion. The integration changes with time, but you're there.
Yeah. So
Ankur,
yes,
Ankur, just since we have all the 3 specialities, T3N0, sphincter sparing candidate 100% is there. Both the trials, are we not over-treating these patients? A single day cure is possible if the same N0 is achieved in histopath also. You know, whether we are contemplating chemo khali day or radiation.
Let me put this question to surgeons, that T3N0, will you at this era in 2024, in the era of Rapido, Prodage, TNT, will you operate this patient?
So how will you assess the response?
No, upfront Amish is asking.
You have assessed sphincter can be preserved, okay, and T3N0 disease is there. both the trials had taken this patient either, avoid radiation or avoid surgery. My point is, if the patient is ready, if you can save my sphincter, cure me in a single day, say surgery done on one day, N0, there is no need of chemo, no need of RT.
T3 lower rectum, we will not do surgery upfront. T3 upper rectum and maybe above the pendular reflection, we will still consider
Recto-sigmoid, not in the middle and the lower one. Middle and the lower one.
So having said that, Amish, in many of these patients, you might end up getting a node positive in the histopathology. And while you might
that is why MRI has to be really investigated.
Exactly. And why you might consider an adjuvant K-pox or FOLFOX, we know from history that giving this chemotherapy in the neoadjuvant setting would be more beneficial for these patients.
And late recurrences, because most of the neoadjuvant go with the hypothesis that the pathological CR will translate into survivals or a better outcome. So I think that in vivo response also one loses. That has been the premise of using the neoadjuvant, in where already upfront sphincter preservation.
So that approach, Dr. Amish, is not, we don't follow
What
this.
would you do, Ankur? Sorry, I'm not supposed to ask you a question, but T3N0, upper rectum, sphincter can be preserved. What would you do?
We'll proceed with the CTRT or a neoadjuvant chemotherapy. Upper rectum surgery. So let's start with OPERA. So OPERA was NACTRT with radiation dose escalation, means you have given standard 45 with 5 weeks of capecitabine. Then do something to this patient, either a contact X-ray brachytherapy or an EBRT, with the intent of preserving the stoma, with intent of preserving the rectum in early T2, T3 rectal carcinoma, which was a phase 3 randomized trial. And majority of these patients were node negative, around 80%, and majority of them were T2. However, 30 to 20% were T3 as well. So this was a 5-year study with a median follow-up of 3 years, and every patient had to was minimum follow-up of each patient was a 2-year. So Dr. Harith, when concurrent chemoradiation has been done and PET scan or an MRI shows excellent response, how many of you or your colleague lose this patient, or they don't turn up to you and they turn up after a year or so that we don't want stoma? Acceptance to stoma is still a problem.
So I don't have a data point on this factor from our side, but I can give a reference that what I've seen in review literature, that almost 10% patients do not come up for surgery ever. And they will, and most of these patients may, when they land up in trouble, that time it's not possible to offer them surgery.
So when they decide that we are...
Nikhil, what's your take on this? Almost 10%.
So when they decide, at some point of time, there will be a mutual agreement of not going for further surgery. We are going to observe it. Does your surveillance, Nikhil, changes? I mean...
So that decision is, as of today's practice, that decision is not taken with surgeon in the room. That is taken by the family. That we don't want to go ahead with any treatment, because as a practitioner of what we are doing today, we are offering surgery to these patients.
The thing is that, first of all, we have to separate so many issues here. So we are talking about stoma. So what percentage of our patients will require APR first? So we have 4 categories here. We are talking about upper rectal cancer, middle rectal cancer.
No, we're talking about classical stoma, middle and lower rectum.
We don't make stoma in these rectal cancers.
Lower rectal.
Lower rectal also. So lower rectal also, maybe only 1/3 of the patients will require stoma. 2/3 of the patients will be able to do a sphincter sparing surgery. Because see, a decision to do a wait and watch versus offering surgery, how much I push them towards a wait and watch versus how much I push them towards surgery, it all depends on whether I'm going to preserve the stoma, what is the age of the patient, what are the comorbidities. So there are multiple factors.
So that's what I'm saying. If the patient, patient and the surgeon mutually agree that the patient is fit but not undergoing surgery, Dr. Harith said that there are good 10% of these patients. So how does an oncologist surveillance change in such scenario?
And we're talking about wait and watch.
Yeah, wait and watch strategy.
Complete response.
So post chemotherapy CTRT, there is a response. We will talk about PR.
Or just response.
Patient is towards you with MRI and a PET scan, and you say surgery, and patient says no, we are not going for surgery. Is something going to change now from oncology perspective? Dr. Kaneka?
So I think firstly, patient needs to understand that what he sees radiologically may not be true. So it's a radiological CR, and if he decides upon keeping in wait and watch option, the surveillance has to be stringent. And if you go by these papers, they do include repeat sigmoidoscopy and biopsies at multiple intervals. And having said that, even with that, there have been reports that even up to, in some studies, 25 to 40% cases, foci remained which were not picked up by these surveillance methods. So that patient needs to be counseled that even with the surveillance, you are at a high risk of recurrence. If we pick it up in time, we can salvage with the surgery. If we don't, then you might lose the opportunity.
So my question is, this discussion should be done pre-start of any treatment, or it should be done post-response with chemotherapy RT?
Ideally, it should be done upfront, because when we send patient to the surgeons, today I had a patient in the clinic. Last day of radiation, now they're saying, can we not just go ahead with radiation and let's not go to the surgeon? Then I said that there is a difference in the dosage we are giving. These decisions should be done upfront. After a month of completion of radiation, you cannot go back and change your doses or add more. So upfront is the time when patient counseling should be better.
Ankur, why did you ask this question? Because you must have experienced something about it.
So because if CTRT is done and a radiation oncologist or a medical oncologist calls the patient after 7 weeks and then they decide that we don't want to go for surgery, then that period is lost. The period of enhancement of that local control, whether with an EBRT or with a contact X-ray boost brachytherapy, which we don't have it in India, we'll discuss that, that is lost. So what is left is again a medical oncologist giving some K-pox or Folfox with what advantage. So we are not able to, so if this discussion is done before surgery, before starting of any treatment, with that same zeal and that same 40-50 minutes, we can judge the mentality of a family and the patient whether he will agree for a surgery or not.
I think all of us have that conversation. I don't think that we don't have that conversation, whether it is at your place or Kanika, or we all have that conversation.
We have that conversation, but the real scenario is that once
still 10% of them
so
doesn't
they get confused.
So
when the response is good, they get confused.
That's what the paper is about.
That's what the reality
you
is.
write on the prescription, you write on the paper, and finally after the CTRT and that duration is finished, then again the question
you give
starts.
the whole plan and understand.
Even if you write in black and
None
white.
of these papers were about the patients which we are talking about. None of these patients were about lower rectal cancer involving the sphincters. Right? So I don't think that's a point of discussion in either of these papers.
So opera study design were two arms, arm A and arm B. So arm A got conventional capecitabine and 45 gray radiation, no break, EBRT, boost for 1 week, and then waiting for 2 months to see the response. The arm B were divided into two parts, less than 3 centimeter and more than 3 centimeter. In less than 3 centimeter, they give contact X-ray brachytherapy in 4 weeks, 3 fractions, and then they waited for 2 weeks, then gave CTRT, then waited for 3 weeks and then assessed response. In patients with more than 3 centimeter, they did conventional CTRT, waited for 2 weeks, give contact X-ray boost brachytherapy for 4 weeks, and then assess the response. So less than 3 centimeter contact X-ray brachytherapy was used so that the radiation oncologist who was doing rigid rectoscopy in these patients can see the tumor 3 centimeter, give it so that it doesn't disappear. In more than 3 centimeter, they could feel the induration and the ulcer and then gave it later. So Dr. Kanika,
so the concept of giving it later was based on the fact that the KEV photons, X-rays cannot go beyond few millimeters.
Yeah.
So they were working like an onion peel. With each session, a peel of a centimeter was shredding off, so that is why it was fractionated. The ones which are less than 3 centimeters, you could do upfront, whereas the ones which were more than 6 centimeters, you had to make it amenable to contact therapy. So that is why that subgroup division.
So I have to call 3 radiation oncologists yesterday to understand what is contact X-ray brachytherapy, how it is done, where it is done. So where this paper came from, this paper came from a single center experience in France, which was Lyon, where they do contact X-ray brachytherapy. Dr. Ritesh, do you have an applicator with you?
There was some papillon technique, Kanika. It's the same thing.
So it is the
So
same
it was
concept.
there historically long back also. In 80s it was practiced and then it was discontinued. So it did not show change in results.
So I asked Dr. Anand, he was not aware.
So the
He
machine...
was not aware where in India we are doing it.
No, but papillon technique was done in Adyar. They were doing it at that time.
So the paper itself said they have the experience of 50 years.
50 years, okay.
So the concept has been there since 80 years. The Philips machine of contact brachytherapy was not made. So since it was not made, nobody was practicing it. They launched these machines somewhere in early 2000. And from 2004 and 6, a lot of people in UK have it. In India, we still don't have it. People send referrals there, but people still don't have it here. People have tried interstitial and sorbo. People have tried that as an alternative, but with some limited success.
So let us see who is funding the trial.
Arian. It is the company who's made this new machine is Arian.
So brachytherapy is being regularly used at Tata Memorial by Dr. Reena for these low rectal small volume disease. So almost 100 patient cohort
Ritesh,
has been done.
How long is an applicator and how long we can go inside? Because more than 6 centimeter, less than 6 centimeter, there was some...
I think in this applicator personally I have not seen, so but this was not meant to go beyond 6 to 8 centimeter as far as I understand.
There are sizes, so the maximal size they have is of 10 centimeters.
So Ankur, your task again further is, if this technology of radiation is not available or not going to be available, then what do we take from this paper?
Yes, that's what... So with the, I'll just rush up because we have 3 minutes only for this paper. So the primary outcome was a 3-year without divergent stoma survival, and secondary outcome was CR, near CR, PR, stable, early and late treatment toxicity, and bowel function assessment with a score in this paper. So assessment was done at week 14 and then at week 20, and if there is some uncertainty at week 20, it was done at week 24. So response at week 24 was determined as the best response, and the patient was followed every 3 monthly for 2 years and then 6 monthly there onward. Any surgery or local or distant relapse was reported. There was no patient who was lost to follow up in this study. So all these patients were holding on. So median age was 69, way above our rectal cancer patient. So 70 years was a median age. Chemotherapy dose reduction was just 20%. 7 patients had an interruption in CTRT, which is much, much lower than our practice. And adjuvant chemotherapy was not mandatory. So at 14 weeks, we got some response, but it's good to see that even at 24 weeks, 6 months post the definitive treatment, the response rates were increasing. And in group B, the near CR was 81%, where contact boost brachytherapy was given at 14 weeks, and it increased to 92% of near CR at 6 months. And so they also divided the population less than 3 and more than 3. So at 24 weeks, which is 6 months, the near CR was 97% when contact X-ray boost therapy was given for tumor which are less than 3 centimeter with or without nodal positivity. So the 3-year organ preservation in the whole group was 59% versus 81% in group B, 63% versus 97% if we divide it into less than 3 centimeter. If it is more than 3 centimeter, 55 versus 68%. So this is a organ preservation rate. The red one is contact boost brachytherapy. The blue one is the conventional one. So contact boost brachytherapy, if patients are selected T2, T3, N0, N1, so we can have in less than 3 centimeter, 81% of the time can actually be without a surgery or without stoma. So 3-year cumulative incidence of local recurrence in this population was 23 versus 15, means those patients who got brachytherapy and it was less than 3, it was in total population was just 15%, and if the tumor is less than 3 centimeter, the chances of local recurrence without surgery was just 5%, and 97% of the local recurrence happened in rectal wall only, which can be easily taken care of. So last message which Dr. Atul Sharma has to emphasize. So patient who wish to avoid surgery, patient and the doctors who wish to avoid surgery with a wait and watch approach, present locally with a growth which later on can be offered with a surgery or a salvage procedure without compromising their chance of cure and with no undue surgical toxicity. So it is established by giving contact X-ray boost brachytherapy, high radiation dose can be delivered to achieve sterilization of that area. So without compromising cure, without compromising recurrence. So Dr. Atul, can we omit surgery in such patients?
Sir, when you answer that, one more question. How much of the local recurrence would be accepted according to you? 10%, 20%, 30% for us to even adopt this method?
All right. So basically, so I'll start with that probably. Anything which is not salvageable is not acceptable. I can accept 10%, 5%, 12% as long as that is salvageable. Any recurrence which is not salvageable, probably I won't accept that. So that is one of the important probably I would like to say. So thank you, Amish. Things are not simple. Practice is changing. We want to, or somebody wants to probably remove surgical oncology or something, or the more and more systemic treatment, radiation, this thing, but probably it's not going to happen. And every specialty is very, very important. Really, you see that this thing, the only trial, one important factor, I take it from this particular study, perseverance probably pays. So if I believe in a philosophy that this way this can be done, and I spend my years together, probably someday I will be rewarded, I'll be getting up some kind of the study which will be fruitful in this thing. I do understand this particular study is very, very difficult to probably evaluate, at least in near future in our country, number one. Selection of patients, they require very, very dedicated probably teamwork. Probably you need to sit with the radiologist, probably surgical oncologist, then radiation oncology, they were doing their own endoscopy also. You need to learn to do that after a series of severe this thing. The good part about this study, this was very very meticulously monitored by the Data Safety Monitoring Committee. If you see the dissect the paper, the sample size was probably close to 250. But since they had the planned interim analysis, and based on this thing 1, 2, and then the 3 interim analysis, they said that probably let us publish this thing. Very important aspect of this particular study probably will come to know in near future or next couple of years, because the kind of the dose they have used, probably yet we don't know what will be the side effects of this thing, what will it do to this thing, surrounding organs. Local.
Was 90 grade.
Yes. So in
on the surface,
on the surface. But still probably we don't know. So obviously it is well controlled. And but still probably we don't know 90
grade. They haven't mentioned here, but it is known that 30% cases late non-healing ulcers have been reported by this technique, and so is the bleeding per rectum in up to 30% till 2 years, still 2 years. So yes, there are some, and telangiectasias, a lot of telangiectasias have been
So there will be occasional bleeding because of telangiectasia, and they keep on probably this thing. I did have one patient, I saw a patient last week only, who was treated with the brachytherapy in TMH and this thing. So he also, the main complaint, everything is normal. He got chemoradiation somewhere in the Delhi, and then probably because of complete clinical response, explored possibility works in the US, in probably some of the startup CEO in this thing, did not want to undergo surgery, went to the TMH, explored possibility brachytherapy. Now the main problem, as the time passes, the main problem is that he feels that the quality is going down. He wanted to avoid this thing back, but now every now and often he says that he's having this kind to keep on changing. So as the time passes, the goalpost also shifted in this thing. This particular study, feasibility, probably in high volume center where this thing, the technique is available, probably will be yes. I personally don't know whether there will be effect, what will be the effect of the histology. None of these two papers we haven't discussed the histology. And as you saw, we many times, though this has not been incorporated into the treatment aspect, but personal experience says the signature histology, which we more often encounter, may not be behaving the same way this thing. We don't have anything new for that, but with time probably will tell us whether that is going to be important.
The design was set up in 2012,
yes,
10 years before, so, and it was we'll discuss in this, pre-Rapido and pre-Prodigy.
Yes.
So they didn't had any concept of biomarker or histopathology.
So these all will be coming. So that's it.
Yeah, I have a couple of points about this.
Yes.
Paper.
One, as usual, the devil is in detail. So one, the inclusion criteria are very restrictive. We hardly see any such patients in our clinic, less than half of the circumference and less than 5 centimeters. That is one thing. Two, I just want to clarify for everybody, organ preservation is not same as sphincter preservation. All of these patients would have undergone a sphincter preservation surgery. So when we talk about organ preservation, we are talking about rectum preservation. Yes. Third, when we talk about LAR, these patients would have required a low anterior resection. So the problem after LAR generally for the patient is LAR syndrome. In this patients also, almost 30% of the patients had significant LAR syndrome. Fourth, patient who would recur, those patients would require a salvage surgery. Now, have we done surgery in the first instance? 100% of them would have underwent a sphincter preserving surgery. In this, half of the patient who underwent salvage surgery, they lost their sphincter.
Yes.
So that's a huge price to pay. So, if you look at the overall.
But there were not many of them.
Yes.
That's the question. So there were not many of them. So majority went away without surgery. So that was the main intent of this paper, that can we go ahead without surgery?
I think
all
Ankur,
these non-healing
you can
ulcers, bleeding,
go
that-
to the next, but one of the point which I take from this paper is that even with the conventional radiotherapy technique, what they are using right now, minimum 60% of organs could be preserved. I think that is the take home for me from this paper.
But that needs to be understood that the dosage is 54 gray, the Brazilian protocol. If it is to be chosen to go towards wait and watch, then the dose does not restrict at 50.4. It has to go up to 54.
So we have 5 minutes more for the next paper. 5-10 minutes more, 7 minutes I think. So its the second paper is preoperative treatment for locally advanced rectal cancer, and in this paper the locally advanced definition was T3 positive, which was 50% of the patient, T2 positive, which was around 10 to 11% of the patient, and T3 node negative. So T3 node negative is coming here also, which corresponds to 40% of the patient. Okay. So the chemosensitivity of rectal cancer motivated authors and investigators to use neoadjuvant treatment with Folfox, which could allow elimination of Dr. Kanika and Dr. Ritesh without increasing the risk of recurrence. Do you agree, Dr. Kanika?
So based on this particular paper, we can very well see that almost 90% of patients could avoid radiation.
You know, your
Yes.
paper will come. You
Yes.
agree that
But,
radiation can be removed if the patient responds to chemotherapy upfront so well?
So it is a very small subset, very early lesions which are not in the lower rectal area, at least 5 centimeters above the anal sphincter, and a good biology, not the poorly differentiated ones. And the other thing is that what is the age of the patient? If it is a young patient, maybe he's the one you would want to keep the avoidance of pelvic insufficiencies and other side effects which we are worried about. So I think that is a select subgroup who can entail, but with a very, very strict, stringent criteria of the case selection based on a good multimodality discussion that this is the right patient, and follow-up has to be very
Dr.
intense.
Ritesh.
Patient profile matters. So if your patient understands the complications of Folfox versus complication of CTRT, his means what he works, what is his way of earning his bread. So if he's a guitarist who feels that his neuropathy would affect his body, so eventually you have to give him an option of CTRTs versus Folfox. So we have to analyze the patient, the age, patient profile, everything, then fit into the protocol. These are the protocols, and this protocol which will give you this much side effect profile, and other protocol, then he has to choose.
Yes. So author, investigator also had this in their mind. So when they were giving Folfox to such patients, and they have used super selective chemoradiotherapy at least 10 times in this paper, they have always back up in their mind that they will offer radiotherapy if the patient did not receive less than 5. If the patient did not have more than 20% response rate, they will give CTRT, and or in other circumstances. So chemoradiotherapy was in the mind of authors and investigators, but they tried, and they were so motivated that they did this study. So primary endpoint of this paper was neoadjuvant Folfox with selective use of chemoradiotherapy would be, Dr. Amol?
Yeah, so just wanted to raise a point about the non-inferiority margin for this paper. They have taken 1.29% of the non-inferiority margin, which they say which reflects probably 5% difference in the DFS. We are talking about early rectal cancer. Yes. We are talking about a curative, potentially curative malignancy. If you compare with early breast cancer, in 5% approvals are given, approvals are withdrawn.
Absolutely.
So are we okay with this kind of a non-inferiority margin?
Yeah, we are all okay.
Difference
We're
of
just
DFS.
discussing that a non-inferior with respect to DFS, only chemo and omitting CTRT, and the secondary endpoint were OS, R0 pathological complete response. This was the schema, around 1200 patient, 1:1 randomization of 597 each, and how they were using selective CTRT were unable to complete at least 5 cycles of FOLFOX, tumor response less than 20%. Post-operative chemoradiotherapy was given to FOLFOX patient who didn't got a pathological complete response, and mandatory cycles. So CTRT group B was conventional 50.4 radiation with 5-FU or capecitabine, and post-op adjuvant chemotherapy may or may not be mandated. So these were surgical outcome pretty much balanced, and 98.9 and 99 some. So all of the patient approximately got an R0 resection. The median time from randomization to surgery. So this is important. So if I give 6 cycles of FOLFOX means 3 months. If I give CTRT, then it means, so I'll take 3 minutes more. If I give CTRT, so the initial treatment is done in 6 to 7 weeks. So does it matter when it comes to compliance in rectal cancer? Dr. Nikhil and Dr. Harith.
I don't think it matters.
So 3 months of treatment and 5 weeks of treatment, a patient gets a very good response to FOLFOX. So this we have seen in head and neck. So those patients in head and neck who got an induction therapy, they were so much relieved that they forgot their primary treatment, which is surgery and which will lead to cure. So this chemo sensitivity and so much good response can be seen in rectal cancer, that they don't take care of the primary treatment, which is radiation or surgery. So good response can lead to loss of compliance?
Obviously, that is possible, certainly possible. That is why the initial conversation, education, all that is very crucial.
Yeah. So this paper had a non-inferior in disease-free survival, overall survival, and freedom from the local recurrence. So whether FOLFOX was given or conventional CTRT, FOLFOX was given followed by chemotherapy, radiotherapy, did not reveal if radiation is omitted. So in the FOLFOX group, 94% of the patient at least received 5 cycles of chemotherapy, neoadjuvant chemotherapy. There were 53 patients in this 584 who got CTRT, 8 because they could not complete 6, 38 because their tumor response was less than 20%, and 7 cases as per the physician criteria. So coming on to the safety, which Dr. Ritesh was saying, so those patients who had FOLFOX first had a lot of toxicity in the form of neuropathy, and those patients who got chemotherapy, radiotherapy later had diarrhea in their thing. So major benefit of pelvic radiation we know is to prevent local recurrence, but with the advent of modern therapy, with the advent of chemotherapy and the universal application of RT, the percentage of patient free from local recurrence was similar in the groups, which was 98% at 5 years. So by omitting radiation, the local recurrence free was 98% at 5 years. How do you justify this, Dr. Kanika? Without radiation, we were getting 98% of the results.
It doesn't need a justification. The selection was good. The selection was good. That made the difference.
So
it is quite possible that over these many years, because we were using a standard of care for all patients, so maybe we were over-treating a few segment of patients.
So it was a super selective group of patients which was T2 positive, T3 negative and T3 positive. They categorically took T3C out. They didn't took T4 patient. They don't took patient who have more than 4 lymph nodes. So we were running late. So Dr. Atul, you can summarize. Okay.
So Ankur, you have 8 more minutes. Just relax.
8 more minutes.
Yes. You have 8 more minutes because you have Atul sir has given expert comment for 1 paper. Okay. Now he'll give expert comment for second. No, 1 minute, because this is important. You know how we selected both the papers, and now my thought process over the 1 hour is changing. I think, when we are omitting radiotherapy, what should be our primary endpoint? Our primary endpoint is survival. our primary endpoint is local recurrence or our primary endpoint is quality of life in these patients? Why are we, Nilesh has been all silent so far, and I can request Ankur if he can answer that question, yes, because you are the moderator. What should be the primary endpoint in omitting RT?
It should be survival. And what was the third thing that you mentioned? DFS, OS and?
No, see, here you have seen that with chemotherapy or with chemoradiotherapy, chemotherapy alone is non-inferior. Fine. But is that the criteria of omitting the radiotherapy? Why do we want to omit radiotherapy? Why did authors thought of omitting radiotherapy?
So at least in their dialogue, they've mentioned because of the long-term risks of radiation, like for example, bone destruction and other side effects. Having said that, see, this is not going to be the standard of care. What this is essentially showing you a path where you can, coming back to the super selectiveness, because that is important, this group of patients who are T2, T3, N1, less than 4 nodes, less than 10 mm involvement, no poorly differentiated patients were included in these. These actually take only about 20 to 25% of our patients. Most of our patients are not going to fit in this criteria. Having said that, if there is such a patient, then the option of giving neoadjuvant chemotherapy and selecting those patients who are responding well and completely avoiding chemoradiotherapy is an acceptable alternative to CTRT, and that is the long and short of what I understand about this paper.
So Dr.
Maybe
Amish,
I can, if I get a woman coming to me on Monday who is desirous of having her own child, so maybe this paper will give me an option that I tell her to preserve her ova and go ahead with this, and maybe then once she completes treatment, she can bear a child herself. That would be one situation which has opened up with papers like this.
Absolutely.
Yeah. So fertility preservation currently is the rectal cancer where we would use prospect. Otherwise, prospect does not hold good in practice.
So coming to Dr. Nilesh sir, thing that it looked like a biased paper. Even if you read the discussion part of this paper, they were not against radiotherapy. So what they wrote, we might come with pelvic fracture, we might come with second cancer, we might come with myeloseparation, and these patients won't be able to receive further chemotherapy when recurrence happened. So this was in the mind of authors that they were omitting radiotherapy. So they invited the patients, or the patient enrolled in the trial were invited to report their symptoms and quality of life, although this is not reported in the detailed supplementary also of this paper, and they may enable patients and physicians to tailor their treatment if needed to omit radiotherapy because of any cause or colitis or fertility issue. So these late complications of radiation were kept in mind but again, they have used that super selective. If they are not able to complete 5-6 cycles, if the response is less than 20%, switch to CTRT and complete the standard oncology, which is obvious, rather than moving beyond the obvious. But the longer follow-up of this paper is required to actually come up whether these recurrence come up later, local or distant or metastatic. So the finding in this trial have extended that there is one therapeutic options even in locally advanced rectal cancer by showing that the FOLFOX is non-inferior to the standard 50.4 gray capecitabine CTRT in prevailing the standard of NACTRT, and super selection, which is T2 node positive, T3 node negative, or T3 node positive, and omitting T4 and omitting more than 4 lymph node was the key here. So again, before Dr. Atul sir comes, I will ask this question. So Dr. Harith, can we omit surgery in early rectal cancer now?
Under very guarded situation.
Very guarded situation, and Dr.
Yes also. So it's a minuscule yes, yeah, okay.
So super selection, the trial was done in a very stringent condition. We don't get such patient and such practice in our institutes. And Dr. Kanika and Dr. Ritesh, can you omit radiation with locally advanced? Think of omitting. We are ready to incorporate you if we are not able to give 5 and the tumor response is less than 20. But if we are able to give a dose-dense FOLFOX and our response is greater, are you happy to see it later on?
if I'm practicing at a center, I continue to practice at a center where I'm confident about the radiology. I have a patient who's compliant and likely to come for follow-ups and sustain this entire treatment as well. Because people can drop out during this long course of NACT as well.
So Viraj and Dr. Nilesh, in the presence of biomarker-driven oncology, MSS, NGS, HER2-neu, so is this paper valid? Or you can do something more beyond FOLFOX when it comes to a local neoadjuvant chemotherapy?
MSI is mandatory now. There's no patient of colorectal cancer who should not have MSI. That should be the message. And they can be safely given. The FDA has given fast track approval now for using immunotherapy. For MSS, omitting chemotherapy is only for early rectal tumors for upper and mid, where they straight away go for TME or like the older Stockholm's SCART followed by TME immediately.
So yeah, I agree. There are, apart from MSI status, there's no other biomarker which can change our line of treatment as of today.
Okay, so over to Dr.
Ankur, just in the last fourth question, if you can add, because that will complete the rectal discussion. In a locally advanced, the second point what you have written, suppose we go for TNT and we give chemo, we give CTRT, no matter whatever investigation you do, there is no evidence of disease. Okay. Initially 2012-13, when the first time TNT was reported, there were I think 29 to 30 patients, Viraj will know the exact, who opted out of surgery. Yeah. What is the panelist take on that? And then we can,
So locally advanced rectum, TNT done, restaging done, there's no evidence. So Dr. Nikhil, wait and watch.
So this is more nuanced. Again, we have to first answer the question there that whether we are going to do a sphincter preservation surgery here or a sphincter losing surgery here. That is the primary question we will ask. Two, what is the fitness of the patient? What is the expected life expectancy? Where does the patient stay? How much is it possible for them to come every 3 months for an extensive investigative workup, right? And four, if we have to do a salvage surgery later, what is the fitness of patient withstanding that salvage surgery?
To go with discussion, can I give an example? Yes. Yeah, so it's a 50-year-old MBA engineer living in Greater Noida, lower rectum, T3 and 2 to start with. We have given 6 cycles of FOLFOX, FOLFIRINOX to start with, then we gave FOLFOX, and then we gave CTRT, conventional, 50.4 or 45, and then absolute CR on PET scan, digital, biopsy done twice, there's no evidence of disease. And he's very fit, 50 MBA.
How long is the follow-up?
This is first 14 weeks. And now in 20 weeks and 24 weeks, the CR status is complete. Like it's persistent. Yeah. 24 weeks means 6 months. That was the second paper.
And he wants to avoid surgery.
He wants to avoid surgery.
And then he should be educated.
So
he's
Viraj,
educated. He's educated.
Yeah. So
Dr. Nikhil, we'll start with you. We will wait and watch.
So wait and watch is always an option if there is CCR.
Okay. So you got your answer, Viraj?
But he needs to have every 3 monthly a flexing and an
Absolutely.
MRI.
Every 3 monthly with a DRE, with the proper
2 years.
Yes. So if Dr. Amish has got his answer, may I invite my master, Dr. Atul Sharma, to give comments on the last paper, whether we can omit radiotherapy in locally advanced rectal cancer or not. Thank you.
So I think Amish was talking about, the quality of life and other things. The first thing we are taught in the medicine is that do no harm. So no extra treatment, no more treatment and this thing. Coming to somebody asked about the probably staging system, probably whatever we do, I still consider clinical staging, radiological staging, whatever this thing. Only thing we are probably refining whatever we have been knowing with the MRI, routine MRI, US and all this thing. But still, if you see few of the papers which were published 2010, 11 or plus minus 2 years, there is evidence that if clinically there is no lymph node, patient receives chemoradiation, 20% will have node positive disease. And this is vice versa. So one thing very important is that whatever the staging you do, still we do not know everything. We are still probably not still below the tip of the iceberg. That is number one thing. Second, if really believe in this paper, very meticulously done, I think so. Ankur was talking about that they had this thing that if they don't get the five-fold folks and this thing, obviously they will take them. Response assessment 20%. How many of us are probably they will be able to assess clear-cut response 20%, 19% on 20%? What do we do? But if I have to take this paper in clinical practice, probably I would. Probably we started with the surgery radiation for this thing tomorrow for the rectal cancer. Maybe that we see tomorrow a paper where the chemotherapy is taken out of this thing protocol. Possible. Maybe that we have some kind of this thing. So it will be, I think. So it will be, maybe that just immunotherapy, systemic treatment, immunotherapy with this thing. This is a feasible practice which can be adopted in the clinical practice with the available means and resources in a country or most of the centers. If we see that this, because if we can use the neoadjuvant chemotherapy in T4 fixed tumors, N2 disease, why cannot we use in the early stage of the disease? That's how the science of this medicine is moving and this thing. Now we have the protocol, this thing. So personally, I think if I am given a chance, I do have a patient who is fitting into this clinical scenario and he wants to this thing avoid radiation. After all, the radiation, all treatment have the side effects. Radiation has side effects, chemotherapy has side effects, surgery has side effects, and this thing somebody probably, and I can ensure that he will be followed up regularly and this thing. Side effects, of course, can avoid, then probably I will consider this patient or that patient for this particular protocol. And probably what I've seen the difference in in the government sectors, probably these kinds of patients we would see uncommonly. But I have seen these patients more often in probably where I am right now working in the corporate sector. So I don't say that we don't see these kind of patients. They are definitely there. We should be encouraging these patients probably so that whatever the treatment modality or side effects can be avoided. Only thing that we need to really super selective, like Ankur was talking about, in choosing these patients, they should be followed up rigorously and these things, whatever this thing. We should be working as a team. We should have the radiologist also, very, very important. Radiologist is very important, these kind of this thing. So possibly tomorrow we will be having these kind of patient. I probably will particularly like to go for these kind of situation where the radiation can be avoided.
So but patient forgets that without treatment there is more side effects.
Sorry?
No treatment is more side effects.
No treatment is?
No treatment has more side effects. They will come with more problems.
No treatment has more side effects. So we are reducing the radiation.
No treatment.
Achha, no treatment has more side effects.
They will come with more problems.
So that remains whether you treat or you don't treat. That's what the goalpost changes. If we have cured a patient, head and neck cancer patient, 5 years he is okay, then the only thing every time he will be saying, "Mere ko saliva nahi ban raha, I probably have dryness, thyroid ka problem de diya aapne, mere ko voice mein thode changes ho gaye." The first and foremost he says, "Mere ko theek kar dijiye." Theek kar diya 3-4 saal 5 saal mein mere ko aapne ye problem de diya. So nobody is happy. We all are probably by nature, human beings are probably known to have some kind of the complaints every time.
The strength of both the papers were follow-up. So you have to follow and you have to...
Staging, so investigations, staging and the follow-up.
Zero loss to follow-up in first paper.
Staging was the key factor.
Yeah, initial workup probably.